Hi, in this video I'm going to go over questions that were submitted during the course that I didn't have time to answer. So let's start with the first question here. Can you say more about drug-induced mitochondrial injury, please? Are there particular drugs or classes of drugs that have these effects? Are there ways to counter this if a person must stay on the medication? So there's a pretty extensive list of medication that can impact mitochondria. Those are in the course notes. There's a bunch of research articles that have the list of medications on some of those slides, and I believe it's in the first section, part 1, 9 o'clock 10th, the 9 o'clock 10:30, the first lecture. And there's also papers I put together in your course materials that clearly has a list of different medications there. But some patients are on these medications. Now remember, these medications don't completely shut down the mitochondria. If that would happen, people would die. They just impair their function. So, in a real clinical setting, there's some patients that cannot go off some of their medication for whatever the reasons may be, and you need to know as a clinician that their mitochondria has some degree of impairment just by the medication itself. You still would do everything in the course that we talked about to optimize the efficiency of their mitochondria from as many mechanisms as you can find, but there will be some degree of impairment you should know about from the medication, and even the same medication could have different effects on different people based on lots of different variables. So it is what it is. You see if the medication is there. If there is the possibility to clinically have something done with that, that would be ideal, especially if they're dealing with pain syndromes or chronic fatigue. And if there isn't, you just kind of go through everything we talked about anyways and try to make all the other mitochondrial mechanisms as efficient as possible. Okay. And the other thing to add to that is the one that impacts the complex 3 enzyme, CoQ10, is one of the things everyone knows about. So if people that have taken things like statins, then you should take CoQ10. But any of the other nutraceuticals that support mitochondrial function should be considered. And if you can specifically look up the complex enzyme, whether it's 1, 2, 3, or 4, or 5, which are listed in those papers, then there's different nutraceuticals and cofactors for each one of those. But the nutraceuticals aren't going to counteract all of the effects that the medication, or even most of the effects that the medications are causing. Okay, next question here. How much movement or exercise qualifies as a non-sedentary lifestyle? That's a good question. So let's start with that. I don't know what the actual number is that justifies something sedentary, but there are just people that just don't have any exercise or any kind of movement. They're just sitting all day. So you have to just use your best judgment for that. Next part of this: if a patient has a couple of days per week on average where they crash and can't do much, but have to go up and down stairs a few times a day on those days, and are standing and moving around a bit to cook, are they able to do 20 minutes or so of exercise on other days? Is that enough to maintain some degree of mitobiogenesis? Yeah, you're always developing, any kind of physical activity or movement doing is going to have some degree of mitochondrial biogenesis. It's just how efficient you're going to be, right? So if you are basically just going up and down on stairs and, doing 20 minutes of exercise on any other days, you're going to have some mitochondrial biogenesis activation. It won't be the same as if someone was, let's say, doing a 60-minute run, 4 times a week. So, this is not a judgment thing. It's not good or bad, or there isn't an exact number for sedentary, but more physical movement in general is going to stimulate more mitochondrial biogenesis. So that's really the only concept to assume. So if a person is doing crashing and not able to do much, then that's their mitochondrial energy capacity at that point, and you have to work them through that. And sometimes exercising, they're not able to exercise past that because there's other things impact their mitochondria, like inflammation, oxidative stress, blood sugar issues, multiple variables that are all in the way. So as those things get improved and uncoupling mechanisms get removed from the mitochondria, then the tolerance to exercise could be dramatically changed. So, those are just the concepts we went over. Okay, next question. Do you think quantitative EEG and EEG biofeedback have a role in the assessment and treatment of chronic fatigue and central pain syndromes? Yes, for sure. It depends on the patient, depends on the mechanism. So if you're looking at areas of the brain that really respond to feedback types of rehabilitation and training, and those are the areas of the brain that are actually contributing to their fatigue, then it can be life-changing. However, it's not going to have an impact on fatigue and injury for everyone and everyone's pain syndrome. It really depends on multi factors. So it's definitely something to consider, especially those that have brain injury or their descending pain pathways are not working. Any kind of brain activation, brain therapy may have a lot of potential in those scenarios of fatigue or pain patients. Next question. Would ALS be another web of mitochondrial uncoupling? Do you have any direction to address and slow down ALS? So ALS is basically a proteinopathy where you have a genetic expression that turns on at a certain point in someone's lifespan, and then they get protein aggregates. Usually hits the motor neurons of the spinal cord first, and it's very, very aggressive. So it's way beyond anything we cover in the course. And as far as, do you have any directions to address slowdown ALS? Not really. I've worked with a few ALS patients. I've never had much success in any of the things that I was able to recommend. It's hard to determine success with ALS because how do you know if it's slowing it down? How do you know if anything would have been any different if you did one intervention or didn't do an intervention? So with any type of progressive diseases, and you only have your patient to compare with and not to any other patients, you never know if anything you're doing is going to have an impact. And this is the issue with neurodegenerative diseases, and this is an aggressive neurodegenerative genetic disease. So it would be even impossible to design study designs to really look at things slowing down ALS, because each ALS patient is really unique to itself in real scenarios. So I don't have much to share with you about that. Next question. Does breathing more deeply help to promote helpful aerobic processes? Yeah, so anytime you get oxygen into your system, it's going to help aerobic processes. Okay. Are there other things one can do to promote increased oxygenation? Yes. So the best way to increase oxygenation is to increase your respiratory saturation and demands. Most common one is physical movement and exercise. Physical movement and exercise can impact oxygenation. Other things you can do is you can look at things that improve circulation and blood flow. Things that improve circulation and blood flow would be things like hawthorn extract, vinpocetine. We talked about that, and the nitric oxide pathways. So ginkgo biloba, hawthorn extract, vinpocetine can help with tissue circulation and blood flow by activating endothelial nitric oxide. So that could be a strategy. Making sure the pulmonary barrier is healthy, lungs are healthy, there's nothing going on with the lungs, heart's healthy, there's no signs of anemia, and then also making sure blood pressure isn't too low, because low blood pressure decreases perfusion or pushing blood and oxygen to tissues. So making sure blood pressure are in the close to normal 120/80 range and not in the hypotensive range. So those can be all useful. Okay, next part of the question. What about some of the breathing techniques that emphasize lengthening and the exhale, which seems to soothe the nervous system and settle the stress response? Do they have any negative effects, Knox? No, that's great. I mean, respiratory breathing exercises have profound impacts on autonomic function and parasympathetic activity. So those are all great. As far as the breathing exercises impacting oxygenation directly, I think you're really dealing more with autonomic toning and parasympathetic activity than oxygenation when you're just doing lengthening, exhale, and breathing. However, anytime you take a deep breath in, you're going to increase oxygen to your cells. Okay, next question. Are there any other mechanisms besides the Warburg effect that might contribute to the post-exertional malaise common in chronic fatigue? Yes. So remember, anything that uncouples the mitochondria can cause post-exertional malaise. So it could be the medications that uncouple the mitochondria. It could be oxidative stress that impacts the mitochondria. And then those are the main ones. Those are the main known mechanisms. So inflammation, oxidative stress, and then this Warburg effect are the three main mechanisms associated with malaise. The other scenario is that it's really not even the mitochondria; it's really the brain. So when people have neurodegeneration or brain injury, if they have unhealthy pools of neurons in a certain region and that area of the brain's being activated, they can get severe fatigue and it's really just because their neurons don't have endurance. So when the brain fatigues, the whole body fatigues. So the brain's fatigued, the person can't focus, can't think, everything feels heavy, they feel exhausted, feel tired, they just want to shut down and close their eyes. So besides the Warburg effect, inflammation, oxidative stress, and then neurodegenerative or traumatic brain injuries that impact areas of the brain that are being activated with the exercise can all cause that post-exertional malaise. Does the timing of antioxidants make a difference, just before, just after? Yes, it makes a difference. So I gave you a scenario where with people that have these fatigue issues after they exercise, to use antioxidants directly before and directly after. And we talked about using things like hydrogen water and liquid things like resveratrol, liquid turmeric, liquid glutathione, because they're very easy to digest and they don't really impact causing nausea and symptoms before exercise. And for some people that have chronic fatigue issues and lots of inflammation, lots of stress, they have to take antioxidants before they work out, and they will notice a big difference. And then they'll have to experiment 5 minutes before, 10 minutes before, 15 minutes before, and it's always a good idea if they have such a significant sensitivity and antioxidants make a difference for them when they work out, to definitely take some antioxidants after. There is no specific dosage, there is no specific timing. It's just the concept of antioxidants before and after, and then evaluating the patient's actual response and preference to what they feel is working best for them as the protocol to consider using. Okay, next question. I've been hearing things about excess use of antioxidants as a potential problem. Could you speak to this, please? Okay. There's some in vitro studies that show if you take antioxidants, they can have immune suppression, but you would need a lot of antioxidants. Just like there's studies that show if you drink too much water, you could die, right? There's also some studies that are being done with certain tumors like melanomas and some lung cancers. They show that antioxidants may have an impact on impacting their immune system. However, these are like observational studies with lots of covariates and confounding variables, so we're not really sure how accurately to assess that. And it's an area of like controversy, and anything controversial gets a lot of attention. But for the most part, I wouldn't really think that of that being a big issue. You don't want to use antioxidants as long as in chemotherapy, for example, but on the other hand, some studies are showing that actually works better. So it's not really clear, but I doubt very much you're going to have someone that takes lots of antioxidants that ends up with a lot of health problems. And if that's the case, it would take an extreme amount of antioxidants. I couldn't even imagine what that number would be. And if there's any indication that's happening, is that you would start to see markers of immune suppression. I've never seen that in my entire career. And then how would one know much is too much? Again, I think I answered that. This next part of this question related. What are your thoughts, if any, about hydrogen water or inhalation as an antioxidant therapy? So hydrogen water we talked about. These are tablets you mix with water, and you increase hydrogen compounds that have an antioxidant, anti-inflammatory effect. I think they're very effective, and I use them in my practice right before exercise. It's one of the slides we have for using antioxidants before therapy. I am not familiar with inhalation, hydrogen antioxidant therapy, so I can't comment on that. Okay, next question. I'm thinking of someone who has slightly high blood sugar. She has been unable to get into ketosis due to persistent hunger every 4 to 5 hours, which mimics low blood sugar pattern. What would you consider looking into? What you might suggest to help this person move towards ketosis? Because the number one reason people can't get into ketosis is they're not doing it properly. So you should not be hungry if a person's eating proper ketones. The key thing is most people just don't get enough fat, or they get too much protein. So someone will go on a ketogenic diet and eat an entire whole chicken, for example, all protein, and have very little fat with it, or the proportion of fat to protein is not effective to get them in ketosis. So I mean, 80% of the fats, calories to come from fats. So that's the number one reason. So if someone has slightly high blood sugar and they're getting ketosis, it's most likely that they're getting way too much protein or not enough fats. And they certainly shouldn't be hungry if they actually get into ketosis. That's one of your signs that person is in ketosis, because the fats should be able to manage their appetite. So that's where I would suggest you look at as far as that is concerned. Is there a way to diagnose obstructive sleep apnea other than sleep test in a lab for someone who is sensitive to EMFs and wouldn't sleep in that environment? Do you think that the mouth and tongue exercises can be effective in sleep treatment apnea? So there are like O-rings and devices now that you can measure sleep quality, but again, is the iPhone or a phone device too much EMFs for one person? If that is, then that's not even an option. But if it's not, that could be an easy way to look at sleep apnea. And then, you could have a partner just take a pulse ox while the person's asleep. This is something that is actually very effective, is to have a partner while they're asleep take a pulse ox, put it on their finger, and the pulse ox should always be in the 95 to 100% SpO2. And if they're below 95, and for sure if they're below 90, they're getting into a hypoxic state during sleep. So it will definitely not be as good as an actual sleep study that can look at those levels overnight, because even if you do a spot pulse ox test, you might not be catching them at the right time of their sleep apnea. However, if you do see it, then that's an issue. And do you think the mouth and tongue exercises can be effective to treat sleep apnea? So I'm not sure what you mean by mouth and tongue exercises. There are some people that have like a palate that falls back, and as you activate your tongue and mouth, you can actually you can increase your palatine tone. So it's worth a try. I don't usually use that a lot in my practice, but for some people, they just will need a device. They would need a CPAP machine to really work. But again, if EMFs are an issue, it could be a little bit difficult to get that accomplished. So you might have to really look at head position. You might really have to look at some of those mouth devices that are available. We talked about in the course to help change the anatomy of their respiratory pathways while they're sleeping. So that's the best I can do to answer that. Okay, next question. How does AST level reflect mitochondrial dysfunction, suggesting Alline cycle dysfunction? AST is not. It doesn't. Let's just put it that way. AST is it's not directly related to mitochondrial dysfunction. So it's a transaminase. AST is a transaminase that really moves aspartate across cell membranes, and it's not a good indication of any cellular function directly. AST is leaked into tissue, and if tissues break down, AST levels go up. So I think as a surrogate marker, it really wouldn't be a good marker for mitochondrial dysfunction. Okay, next question. Postmenopausal females with Hashimoto's does not respond to estrogen clearing methods. They write Estrovite, Testanex, Methyl SP, Metacrin. So Estrovite, these are all Apex products. Estrovite contains flavonoids and nutritional cofactors for glucuronidation, sulfation. Methyl SP supports methylation to clear out methylation pathways. Testanex is a compound that is a natural aromatase, and Metacrin DX is like a general compound to support biotransformation. So it sounds like there's a postmenopausal female patient that just isn't able to clear their estrogens. The main suggestion with females that have high estrogens is to lose body fat. So a lot of estrogens are just stored in body fat, and despite supporting liver detox pathways, if they have lots of body fat, you may not be able to get their estrogens cleared until those body tissues are reduced. So that's not uncommon. You see that all the time. And the other thing is just to make sure they're not getting chronic exposure to estrogens that could be from cosmetics, as well as potential food sources. So and sometimes you're just kind of stuck, and you have a really hard time clearing those. Now, I would say if you can't get their estrogen levels down, things like selective estrogen receptor modulators, like genistein, diadazine, that's like an estrovite, that's still protective, and it's a good idea. But a lot of these scenarios where I've noticed where that's been an issue, it is really about getting their body fat reduced. And then if they're very skinny and they don't have much body fat, you definitely want to look at exposure to various things. And sometimes you just can't figure out. And I've been in those clinical scenarios as well. But I think exposure and reducing body fat are the two most common. Number 13, for Hashimoto's, what other food besides gluten or casein can trigger it? There's a lot of foods and lots of things that can trigger Hashimoto's as far as foods go. We did an entire course on Hashimoto's, and we talked about even specific cross-reactive foods that have molecular mimicry with different target proteins. It's beyond this Q&A. You can check out the Hashimoto's Kurazi Institute course for a detailed presentation on that. Okay, next question. Can you explain how you diagnose Epstein-Barr virus reactivation by assessing IgG-IgM antibody testing? Do you find early antigen the most useful of the EBM marker? So IgG-IgM is not going to be that great. The viral capsid antigen marker would be very, very useful as well. And basically you really want to just go through and do the complete Epstein-Barr viral profile and then look at each of the different biomarkers that go up at different parts of the infection, and then that can give you a general idea if it's reactivation or activation and so forth. So just the IgM antibody is really not useful alone. You really want to look at the early antigen, the viral capsid antigen, and the whole Epstein-Barr profile to determine what stage you're in. Next question. Why do you prefer mold antibody testing versus mycotoxin antibodies when assessing for myotoxicity? I don't have a preference for one or the other. I don't know why that was thought. Each test is telling you something different and giving you a different expression of a physiological response. So it's not that I prefer one or the other if one is better than the other. They're different types of tests are telling you different response. So mold antibody testing with like IgG is telling you exposure. IgE means that their immune system has now developed sensitivity to it, and they will always be sensitive to that at that point. And once they do develop IgEs, the only option that could really be helpful for them, it could be like low dose antigen therapy by an allergist, where they give them small doses to kind of break out of that IgE pattern. Mycotoxins may or may not be involved with mold exposure issues. It just depends on if the mold themselves are releasing a lot of mycotoxins. The other issue with mycotoxin levels is that you get mycotoxin exposure from foods that you eat. So mycotoxins are typically measured in urine, not so much antibodies. But they're all just giving you a different expression of what's really happening as far as exposure to that type of immune response. So they're all useful. It just depends on you. Like in a real setting, you just have to go over a patient's budget and really determine what's going on. Like mycotoxin levels are not going to tell you if they develop IgE reactions and now forever sensitive to it. So that could be a benefit if that's what you're trying to evaluate. However, you could have someone's IgG levels and IgE antibodies elevated months and months after the exposure, and you want to know if they're actively getting some reactions with mold as an antigen, and that's where, let's say, mycotoxin levels could be much more useful. So they all have their pros and cons. Next question. Would you scramble eggs cooked in butter in a frying pan? Can be considered a fried food to be avoided if one is avoiding fried food. Yes, if you're cooking butter in a frying pan, then it's fried foods. Next question. Could chronic inflammation, such as from a persistent infection or mold exposure, interfere with one's ability to get into ketosis? I don't really see how. I know lots of people are not getting into ketosis, and there's a couple of reasons why they're not getting into ketosis. One of the reasons they're not getting into ketosis, like we talked about, is they're not getting enough fats to protein ratios, so they can't really get into ketosis. But you look at what ketosis is basically beta oxidation, which means you're taking a triglyceride, breaking that triglyceride into fatty acids and glycerol. And those fatty acids and glycerol, or those fatty acids specifically, then become acetyl-CoA, and it goes in the mitochondria. That's the pathway. So it's basically beta oxidation. I don't know of anything in that beta oxidation pathway, okay, that specifically is uncoupled by inflammatory cytokines, for example. So, it could be an internet theory circling around for everyone, and then everyone's now thinking they have to get rid of mold or everything else, which is kind of the world of folklore nutrition. Make up mechanisms that make sense to someone other, but they're not really real. The other thing you have to understand, if you look at beta oxidation is using fat for energy. There are some people, especially those that are extremely sedentary, who haven't moved, and they don't have activation of the enzymes that are used in beta oxidation. So, for some people, they will physically have to get their beta oxidation pathways turned on by exercise and movement, and then caffeine does stimulate that pathway. So if they can, maybe drink some coffee or take green tea, and then get some physical exercise in, in the morning while they're still in their fasting state, right before they eat anything, they can start turning on more enzyme activity at beta oxidation, and then that may be easier over time for them to get into ketosis. But I don't think, if you're searching for an infection or mold, you're going to be doing a lot of searches for them and maybe wasting time. If you want to get someone in ketosis, optimize the beta oxidation pathway through caffeine, stimulants, exercise, in a fasting state, and see if that can make a difference. Okay, next question. How does the cell danger response affect the mitochondria, and what can be done to eliminate the cell danger response? Cell danger response is just any kind of environmental antigenic trigger that triggers the immune response and the stress response. How do you eliminate cell danger response? Don't get exposed to chemicals and antigens. There's no way around that. Everything we talked about with mitochondrial signaling pathways, how different signals impact the mitochondria, and the mitochondria react, inflammasomes and reactive species are technically part of what's known in physiological journals as the cell danger response. Next question. How to inhibit perseveration? It's not repeating your head. If you have perseveration, your frontal lobe's not healthy. It's just that simple. You want to inhibit perseveration, increase your frontal lobe function. Focus, attention, concentration. So really work on developing skills that require a lot of focus, attention, and concentration. Whether that's board games, whether that's physical activity, whether it's concentrating on something academic. If you increase your function of your frontal lobe, then you will no longer have perseveration. In times when you're really tired and fatigued and exhausted, not to say there's nothing wrong with your brain, but if your brain is really fatigued, exhausted, and tired, it's really easy to have perseveration where you just keep having that song in your head and song in your head and song in your head. So if you can increase your mitochondrial endurance, mitochondrial activity in your frontal lobe, then you should have less perseveration. Should modified citrus pectin be avoided on a keto diet? I've never heard this question, but ultimately, I guess it would depend on how many carbs modified citrus pectin has, and even though maybe high in carbs, it's high in fiber. So I really don't think it's a factor for ketosis. So I think as long as you're staying within your carb limits, it shouldn't be an issue. 21. What is the difference between hypoglycemia and reactive hypoglycemia? Okay, so let's talk about that first. So hypoglycemia and reactive hypoglycemia. So hypoglycemia, by clear definition, means glucose levels are below a normal reference range. And, sometimes the term functional hypoglycemia is used because the reference range is not as strict as the lab range. So, some labs have anything below 60, the marker for hypoglycemia, so that's the hypoglycemia laboratory range for low blood sugar. But, clinically, we notice blood sugar levels below fasting levels of 85 really start to cause all the symptoms. So that's what's called, for example, functional hypoglycemia. Reactive hypoglycemia just means your blood sugar is dropping. It's reacting to your diet. It's reacting to physiological mechanisms. So reactive hypoglycemia means you just forgot to eat for a very long time, and that's the reason why your blood sugar is dropping. So your drop in blood sugar is reactive to some kind of lack of activity or something that happened to you. You could have a severe stress response and burn up all your blood sugar, and then have blood sugar drop, and that's blood sugar reactive to a stress response. So those are the different terms. Could you please speak more on impaired pancreas glucagon function in regards to nocturnal hypoglycemia? Yeah, I mean, just like the pancreatic beta cells release insulin and then they get depleted, the pancreatic alpha cells can also get depleted, and you have inefficiency to produce glucagon. So you can have people that have been hypoglycemic for years and years and years, and they just eat sugar all day and don't eat, and they constantly get these needs to raise glucagon to get their blood sugar back up, and over time, they lose their endocrine reserves. So that's not uncommon. There's a study that showed green tea extract can actually help with glucagon activity. And I'll have patients that have really severe nocturnal hypoglycemia issues, and issues where clearly glucagon's impacted because they're just dropping hypoglycemia all the time. Take non-caffeinated green tea extract throughout the day to help them. But it is part of it. We talked a lot about this question in the Crosby Institute Diabetes and Dysglycemia course. That might be something you want to check out if you haven't taken it. Okay, next question. Would you consider beta-hydroxybutyrate supplements for someone who is not on a keto diet, such as nocturnal hypoglycemia? Yes. You could absolutely have patients take exogenous ketones before bedtime, and it may be helpful to some patients. You'll have to experiment with them, but it can absolutely be used for nocturnal hypoglycemia patterns, and it's sometimes very, very effective. Next question. Can you boost estrogen and progesterone in a postmenopausal woman if you support mitochondrial biogenesis? Yes, theoretically you can do that, but for sure, I mean, activities that increase mitochondrial biogenesis, like exercise, clearly show they can increase hormone level production. So, when you look at natural ways to boost hormones, the main mechanisms that impact mitochondrial biogenesis may have some potential impact on that. I don't know of any studies where they just looked at someone's hormones and mitochondrial activity, let's say in a tissue, and then counted how those things changed, if the hormone levels changed. But the theoretical model would sure support that those mechanisms can be in place. But I don't think there's been a clear study that shows that relationship. Next question. How can we test for mitochondrial DNA disease? There's labs that do specialty testing for DNA mitochondrial diseases, genetic diseases. I use a lab called Athena Diagnostics, ATHENA Diagnostics. It is very expensive. So just so you know, it could easily be several $1,000s to screen for when you start to look at mitochondrial genetic diseases. So check out their website, and they have all the main tests you need for that. Okay, next question. Can you go through your preferred chelation protocols, please? Well, let me do the best I can answer this, because this could take a whole hour itself. For the most part, when you look at toxic metabolites, certain toxic metabolites are persistent organic pollutants, and certain toxic metabolites are non-persistent pollutants. Persistent pollutants are things like heavy metal, lead, arsenic, mercury, like let's say heavy metals. And those are the ones that you would consider chelation for. For non-persistent pollutants like pesticides and BPA, compounds that could be in your laundry, like formaldehyde, those types of things, they all can go through biotransformations. So for non-persistent chemicals, you just need to optimize biotransformation pathways, phase 1, phase 2. Lots of nutraceuticals can do that. Movement, exercise, sweating, healthy bowel movements, they're all useful. But if you're dealing with actual persistent chemicals like heavy metals and so forth, and you're trying to look at removal, in the previous coursework we talked about, before you start chelation, make sure they're healthy enough. Like, you don't want to take a frail 80-year-old that has dementia diagnosed and is barely functioning, and then you want to all of a sudden try to get their mercury out to slow down their Alzheimer's. You could actually put them over the edge and really make them worse. So remember that the key issue with chelation is that there are some potential redistribution issues. So EDTA, DMPS, DMSA are all chelators, but they all have the ability to redistribute in tissues. So you really want to make sure the gut barriers are healthy, their blood-brain barriers are healthy. You can do labs to look at those. And then, glutathione is a natural chelator that can be used. It also heals the blood-brain barrier and lung barrier. And then, so I think that when you go least to most aggressive and least to most likely to cause reactions, you can start with raising glutathione levels and then IV glutathione as a way to help with some chelation that isn't going to be an issue with people that are really frail and compromised. The next level past that would be to have a person take something like oral EDTA, DMS, and TPS, and make sure they take fiber with that so they can help clear their metal binding compounds at the same time. And the next level past that would be that they actually do IV, DMPS, DMSA. So those are the different degrees of intensity you can do with chelation protocols. Next question. Do you have any thoughts about whole body photobiomodulation for mitochondrial support? So I don't have any experience with photobiomodulation, so I can't comment. Next question. Have you found that some chronic fatigue patients are suffering from mast cell activation syndrome? Yes. So we talked about mast cells. Mast cells create significant histamine. Histamine not only has an inflammatory response in tissues, but chronic inflammation can impact mitochondrial function, mitochondrial uncoupling. So there's for sure people that have this mast cell activation syndrome pattern. They have the dermatographia. You can write over their skin, and it's definitely a variable to consider. Next question. Is urolithin A useful to encourage mitophagy? I don't know. I don't know what urolithin A is, so I've never used that, so I can't comment. Is the OAT a good way to assess whether the Warburg effect is in play? Any comments on specificity, sensitivity? Welcome. So again, I don't have experience with the OAT, so I can't comment. Do you have any knowledge about the links between pathology of fibrosis in the organ, bronchiectasis, IPF, and mitochondria? Also, do you have any experience of administering nebulized glutathione for IPF orally? This is a very general question. Fibrosis, like liver fibrosis, is different than pulmonary fibrosis. Fibrosis, for the most part, is a reaction to an inflammatory mechanism. So you're dealing with inflammation in the tissue. So, for example, you can have alcohol-related hepatic fibrosis, liver cirrhosis. You could have hepatitis C cirrhosis. They're both inflammatory and destructive of the tissue, and that's where fibrosis takes place. For example, in the liver, in the lungs, you have inflammatory triggers, infections, and things that lead to fibrosis. Ultimately, you're trying to get to the mechanism that's causing injury to the tissue to deal with fibrosis. We talked about using nebulized glutathione in the neuroinflammation course. It can be effective for people, especially with pulmonary issues, to help get antioxidants to that. So, glutathione, again, you can take it IV, you can take it orally, there's also some people that take glutathione enemas or have suppositories, but they all have some potential. I don't know what major difference it would make for different fibrotic conditions. It's a very general question, so it's hard to answer. Have you looked into the relationship between deuterium and metabolic function, or the use of deuterium deficient water? No, I don't know much about it, so I can't answer that. What are markers for systemic inflammation? So all your inflammatory cytokines, the whole list of them, they're all markers for systemic inflammation. C-reactive protein, ESR, ferritin, which are the acute phase reactants. We talked about those in the course. Those are all markers for systemic inflammation. How do we address brain injury with inability to dampen reticular activating system? There isn't a nutraceutical or a general protocol that is specific for brain injury alone. It's a comprehensive approach. If anything, you should definitely get familiar with the crossing into neuroinflammation course because there's this huge microglia, neuroglial priming associated with brain injury. So I would suggest learn everything you can about neuroinflammation and glial priming. We go into that in that course in detail. And it takes us 2 full days to go through. So check out that material. Is there a way to test if a patient has the Warburg effect? Not in a real clinical setting. These are really done in labs where they can actually measure lactate levels. Your biggest clue is that they have that metabolic type pain, aching when they do any kind of physical activity. And then the next part of this question, are we assuming all ME/CFS patients have it? No, all ME/CFS patients do not have it. So it's very common in that group. It's also common in the fibromyalgia group. So your biggest clinical clue is movement activity where they use their muscle, produces lactate, and then muscle tissue has nociceptors that are very sensitive to lactate, and that's why they feel in their muscles more than anything else. There's changes like that happening in other tissues as well. It's just they're not experiencing what's happening in an organ system with lactate or other things. So it's more of a clinical finding, and the testing they do for this are done like in physiology, sports medicine labs, and metabolic muscle laboratories. So it's not like you can run a lab test for that. And it's happening in the tissue, so you can't really even measure in the blood. Okay. Next question. When assessing testosterone in men, is it more accurate to run total testosterone with sex hormone binding globulin and albumin and then calculate free and bioavailable, or just order free bioavailable or total testosterone? I mean, if you're looking at assessing testosterone, you should do total testosterone, free testosterone, sex hormone binding globulin, estradiol estrone because they antagonist estrogen, and you should do LH. The reason you want to do LH is to determine if it's primary hypogonad or secondary hypogonad. We went all the different feedback hormone loops in the infertility course when we talked about the male fertility factor. But if you really, really want to assess testosterone properly, LH, total testosterone, free testosterone, sex hormone binding globulin. I think the free ratios are pretty good without having to do any kind of calculations. How would you keep a chronic fatigue syndrome patient on ketogenic diet if they are losing weight fast? They just need to increase. It's very simple. Increase their caloric intake. If they're on a ketogenic diet and still losing weight, increase their calories. So have them eat more caloric rich foods, and they may need to. If you have some people that like have a Warburg effect and they have to get in a ketogenic diet to have fuel and energy, then they're going to need to eat more. The problem with some of these people that are losing weight is when they get into ketosis, they're just not hungry. So you have to let them know, like, it doesn't matter if you're hungry or not, you're losing weight while you're in ketosis, so you're going to have to eat more frequently, even if you're not hungry, until you can unwind the other variables and factors that are impacting the chronic fatigue syndrome. Next question. Can you speak to the findings for UK autopsies where 3 or 4 women diagnosed with ME/CFS were found to have dorsal root ganglitis? Well, again, I haven't seen that study. Even if it's there, like, this is why to do statistical analysis and data analysis. So I can't comment on it because, it's not. I don't know what the actual study was that showed that, but it's not surprising. One of the known pathophysiologies of myalgic encephalomyelitis, chronic fatigue syndrome, is neurological autoimmunity. So if they look at any target neurological tissue, it's always possible for them to have it. And even in some papers that we went over in the course and that put in your course materials, they clearly show there are lots of different neurological autoantibodies involved in ME/CFS patients. So all I can say is it's not a surprise. That's part of the pathophysiology of some of them. Now, 3 out of 4, like, that's not real. Like, scientists would never say 3 out of 4. So if, like, they would say like a risk ratio or an odds ratio. So like 3 out of 4 makes me just immediately a red flag of like a dental commercial, like 3 out of 4 dentists prefer this toothpaste. So I'm not sure where this is coming out of. 3 out of 4 women diagnosed. That's not real scientific terms. So it makes me question whoever that source is that has made that comment. Okay, next question. For ME/CFS patients with gastroparesis, would a ketogenic diet be contraindicated since small amount of fat is permitted for gastroparesis? Yeah, I mean, if they have gastroparesis issues, they cannot tolerate fat. You're not going to be able to do a ketogenic diet. That's just unfortunate, but that's the way it is. Then decreased fiber is also recommended, which is quite challenging. Then white might be an alternative. You may be stuck in a situation where you can't implement these factors because of their gastroparesis. So, these are clinical situations we all face. We want to do something, but there's other things in the way that are preventing it from happening. You made experiments, see how much fat they can tolerate, if that allows them to get into ketosis. That's all you can really do. 39. One slide indicated that mitochondrial dysfunction reduces HRV. How would you explain heart rate variability? How would you explain increased heart rate variability in the serious CFS-ME patients, parasympathetic hyperactivity? Yeah, so heart rate variability is going to just go up when the sympathetic nervous system and parasympathetics are not working well. So whether that's neurological, that could be a factor. Hypoxia states, where people don't have enough oxygen, can also impact heart rate variability. So whenever your oxygen levels go down to get hypoxic, your heart rate immediately goes up to try to get oxygen delivered to tissues. Even dehydration, where you have lack of oxygen being delivered to tissues in H2O form at a cellular level, can increase heart rate. So heart rate variability can go up with dehydration. It can happen with anything that causes hypoxia. It could also be completely neurological. They have a dysautonomia effect. Is lutein useful to encourage mitochondria? That's another question. I don't know. I've never used it. I understand that a non-genetic version of something like Ehlers-Danlos syndrome is relatively common among ME/CFS patients. Can you speak to why this might be the case? I've not heard of that, and I've not seen that, so I don't know why. Would you recommend starting HRT for a 62-year-old female with menopausal symptoms lasting the last 10 years? I have no idea. I can't make a comment about what you would start based on one symptom. Like, just because they're 62 and have been menopausal for symptoms doesn't mean anything as far as what treatment to start. So, yeah. How should one address low SIJ activity? Well, low SIJ activity is kind of like weakened immunity. It's not like one thing directly can do to increase immunity. And just like SIGA, there isn't like one nutraceutical to take to increase SIGA, just like there isn't one nutraceutical to take to always help with low immunity. And, when there's low SIGA, there could be something impacting B cells for the total immunoglobulin compound. The SIGA levels could be low because they're constantly getting exposed to triggers that are using up all their SIGA levels, like someone who's gluten dairy sensitive and they still eat gluten dairy. You could have SIGA levels be compromised from like chronic stress responses. So there isn't like, just like if someone were to ask you like how do you address low immunity? I mean, it's multiple things. It's like stressors, sleep, healthy nutrition. Do they have some kind of something weaken? Is there any chemicals that are impacting their immunity? Do they have any chronic pathogens? There isn't one general answer. So the way you address low SIG activity, just think of it as how would you address someone who's got weakened immunity? And then you try to look for all the different variables that are involved. Okay, that question again, 45. What is your opinion on long-term use of low-dose naltrexone for chronic pain? Would LDN be contraindicated for gastroparesis at very low doses, such as 1.5 milligrams? Low-dose naltrexone is one of those compounds that natural opioid activity, it has a window of time. For some people that's helpful, and then it just stops having an effect for many people. So I think with long-term use, you're just not going to notice the effect on chronic pain as much, and your receptors will just get used to that type of modulation, and then other stimulators will get amplified and still have their effect. So in and of itself as a single treatment, it's not going to unwind any chronic pain pattern. And it may have some benefits in the short term, but over long term, I'm not sure what role it plays in actually unwinding the pattern. I would really just suggest going through the model we talked about. Would low LDN be contraindicated for gastroparesis at very low doses, such as 1.5 milligrams? I don't know. I don't use LDN within my scope of practice, so I don't know, and I don't know what role it plays with that. Okay, so I think same question there twice. All right. Okay, so those are the main questions that were submitted. If you did submit this question, thank you for submitting your question and for taking the course. I hope I was able to answer your question. I did my best, and thank you for everyone again for submitting and taking the course.